Welcome, everybody. Welcome. Well, hello. Good evening, greetings, wherever you are in the world. My name is Michelle Faggart, and I'm honored to serve as a co-president of the Harvard Alumni for Climate and the Environment, or HACE. We are a shared interest group full of volunteer-led global community of alumni, and we are passionate about making a difference in addressing the climate crisis through a variety of different pillars, including education, community, and action. We have a number of ways to get involved with HACE, which I will share with you in just a moment in the chat. But we have a lot of wonderful programming, like the very exciting lecture that we will have tonight on climate resilience for frontline healthcare clinics. So whether you are a climate expert who's been working in the space for years, or you are just getting started, HACE has a spot for you. We hope to see you again at further events. And without further ado, I will turn it over to my colleague Trevor in New York.
Thank you, Michelle. Thanks, everybody. There are people, but unfortunately, you can only see me, but we have people here. So thanks everyone for joining in person or on Zoom. So we have a hybrid event right now, as you mentioned, Michelle, with folks in multiple locations, live, in person, and virtual. So we've got, we have a climate and health series. This is part 2 of the series. Tom, myself, and Eleanor put that together. Tom Polton is in Cambridge right now. This is the second event in the series so far, as I mentioned, and it's, there's a lot happening right now. And so it's essential right now to also showcase the work that Harvard alums, students, faculty, et cetera, are doing to address, these critical issues. Our first event was on climate change and mental health. We are grateful for the partnerships for this series across the university, including with Perkins Eastman, where we are right now, and Chan, School of Public Health. If you are a member of the Harvard community but are not currently a HACE member, please join. Current students, professors, alums are all welcome. At the end of the program, we'll share resources that can be used by attendees for pursuing resilience in their own communities and just as general information. So we're gonna just to get started, we'll have presenters in 3 locations. We'll start here in New York with Eric Fang. We'll go then later to Dr. Caleb Dresser with Tom in Boston, and Dr. Latoya Storr in Grand Bahama. Tonight we're talking about climate resilience for frontline clinics. As you all, I don't have to tell you all, but of course, increasingly intense heat waves, wildfires, hurricanes, other hazards, disasters threaten the ability of hospitals, healthcare, clinics to provide care and keep patients healthy. So our presenters will discuss their first-hand experiences in confronting severe weather challenges and what actions can be taken. They'll also draw from a comprehensive toolkit that's available to support efforts in everyone's communities. We welcome questions. We will have time for Q&A, but please post them in the Zoom chat or Q&A function. We'll get to them most likely after everybody is presented. And for now, we'll keep everyone on mute. And without further ado, Eric, I'd like to welcome you. We're hosted here at Perkins Eastman, and great to hear from Eric about what they have done here in New York on resilience for healthcare clinics. So I'll pass the mic literally to Eric.
Thanks, Trevor. First, welcome here to Perkins Eastman. This is my place of employ. I'm a principal here. I lead our planning and urban design practice, and we worked a lot with Eleanor and Trevor from our group at the Harvard Club. We have a climate and resilience special interest group. That's a little bit of a pitch, but we'd much rather have you here. And by way of introduction, we're a global architecture and design planning firm. We have offices in, about 20 odd locations globally. And we're based here in New York. We work across a wide range of practice areas, including healthcare. That's one of our major practice areas, and also including residential, hospitality, university research, and so forth. So My background, I'm an architect. I've done a lot of work in coastal areas, waterfronts, and so forth. And by virtue of that, I've gotten very, very heavily involved in coastal resilience. And so I have put together, it was a combination of a bunch of different things, but I think it introduces some of the context. First of all, just by way of kind of overview of what some of the vulnerabilities and risks are here in the New York area. What's the matter? Can you see this? For those of you who lived in New York for a while, particularly through the last couple of cycles of major storms, the big kind of things that we're living through with regard to the coastal issues and flooding and so forth are storm surge and high tide flooding, right? So, and then second is sea level rise, two related but separate things. There's in our work planning around waterfront areas, coastal communities, we often work at the time scale of decades. And so we have to kind of take these things into account, both for existing and for new communities. I'm not going to go into all the details of the numbers, but just to show you this, to give you an idea of the variability of the projections and the high degree of uncertainty as to what you need to plan for. And just be mindful that planning for 38 inches of sea level rise versus 6 could be the difference of hundreds and hundreds of millions of dollars in terms of site preparation and so forth. And then all sorts of disruption to existing communities and retrofitting and so forth. And we are asking politicians and decision makers and so forth to take action to prepare communities with infrastructure planning, investments, and so forth, but with this high degree of variability. So the question is, what do you place your chips on? And those are great questions. This is in New Jersey. This is also to show the high degree of variability and the probabilities involved, but also it's different in different places as well. Okay. And then explaining what that means to decision makers, stakeholders, residents, building owners, property owners, and so forth, which is it's not straightforward. And so working to figure out different visual methods to explain what these probabilities are. There's a little bit of a layer cake. I'm joined. Factoring in sea level rise, tides, tidal action, the probabilities that will be increasing with regard to major storm events, and then explaining that and making planning decisions based on those probabilities. And then, there's the vertical dimension to that and what that means. And so we have a little stick figure there with the house just to give an idea of scale and what these different heights mean. But also what that means in the horizontal plane and the extent at various levels of sea level rise, inundation, and so forth, that will affect communities, on a map. And, a few inches can mean, hundreds and hundreds of feet. And then the second thing is then that was a series of diagrams explaining sea level rise and risks involved with inundation, storm surge, is the risks associated with high intensity rain events, storms, big storms. So if you think of the first one, you think of Sandy, and then the second, this is more recent, Ida or Henry, which is just they got a good name for that, which is cloudburst flooding, right? And same thing, which is what are the probabilities and at different durations and so forth. So this is not just one storm, but also how long does it last, and that determines how much that's related to the capacity of our stormwater infrastructure and so forth. So again, lots of complicated things. They're all layered on top of each other. These are just some illustrations that if anyone lived through this, they probably don't need reminders, but it is just as acute as some of the coastal issues. That's the thing that we think of first, but I think Henry and Ida really opened up everyone's eyes, just as Sandy did, to the risks associated with cloudburst and the higher incidence of major rain events, which is going to increase as we go with the higher temperatures. There's more capacity for the atmosphere to hold water, and that means more storms, big storms. So now I'm going to talk about, since our object of discussion is healthcare, a little bit about hospitals. And this is something, part of my work, we try to come up with strategies to accommodate big institutions into the fabric of the city. And so hospitals, it's one thing that is kind of interesting is that they, in the US at least, and the West in general, they were associated with poorhouses. So they were usually at the margins, literally at the margins of society and our communities. So you push them all the way to the edge because you didn't want them to be around other people, right? Infectious disease and so forth. And they were in swampy areas by the water because you just push it as far away. People didn't want to be by the water at that time. This is a map of Bellevue and early kind of drawing of Bellevue. And then the question becomes, how do you then deal with the effects of climate change? Actually, I think I jumped ahead. So they were once at the margins, and now they're really at the center of action, right? The city has grown and sort of surrounded the hospitals, right? Because as the cities moved to the water, which many cities around the world have done, and then the hospitals themselves have become an engine of economic growth. So that there's all sorts of industry that grows around them, labs, biotech startups, and so forth. And so now you're fully enmeshed. The hospitals themselves were not just these poorhouses that were at the edge of the swamp. They're now multi-billion-dollar facilities, high-tech facilities with huge investments that a good part of the city's economy depends on. And so the scale of intervention, protection, and so forth, all those decisions become much more acute. So now I'm going to go back. So the question is then, how do you start to deal with this? So there's basically three different ways, right? First is you protect yourself from the water. You build a big wall and you keep it out for as long as you can, which that's obviously limited, particularly when the water is rising, the seas are rising. The second is you live with it, right? You adaptive measures, raising houses, things like that. You see a lot of these protective measures that are being built around subway grades. It's a kind of a stopgap. And then the third is to retreat. And these are the basic ways of dealing with it. And in the end, there's not one size fits all. It's going to be a combination of all the above, based on political issues, community issues. So in our work with healthcare and hospitals, we've employed all of the above. This is the Koch Center for Cancer. I don't know what the full name is, but for cancer treatment, it's on 74th on the west side, right on the east side, right on the East River. And you could see the massive fortifications that have been built, that they're actually operable. They flip up, and that's the fortification. That's the first category, obviously. And a second category we've been involved with this is Coney Island Hospital. Now it's been since replaced with Ruth Bader Ginsburg Hospital. It's in Coney Island, obviously, which suffered major flood damage. Basically was trashed during Sandy. It had to be rebuilt, and we did kind of the first thinking on that, the concept plan. And you can see here, this is an adaptation measure, which is basically restacking the whole order of how hospitals work vertically, right? So the mechanicals, they're pushed up. The generators are up on the roof. The emergency room is elevated. All that stuff this is a drastic reorganization of how hospitals are organized vertically, which is quite important. This is the final result, Ruth Bader Ginsburg Hospital. But this shows the types of things that are being actually acted on, implemented. The New York City Health and Hospitals Corporation, which is responsible for all of the major public facilities in the city, which 16 in all. They have recently released a plan for, assessing what the vulnerabilities are and a plan of action for dealing with those. So there is planning that's going on, actively, right? There's things that are actually being built. If you're in Lower Manhattan, you're familiar with the Lower East Side coastal resiliency. You see some of these big walls and the rebuilding of the park on the Lower East Side. That's protect against, and it's really it's a fantastic piece of infrastructure. People from around the U.S. come and they kind of marvel at it because I think it's been over 10 years since Sandy, but the amount of investment, marshaling of public initiative and so forth it took to get that done, that's a big deal in the United States. The other way of addressing these things is through regulation. So this is an illustration of where we're in, as we're kind of in this crazy world right now. But there have been measures taken along the way to deal with these effects. So in particular, with regard to healthcare facilities, there was a measure. It's first adopted in 1977. It was an executive order. This is Carter administration that recognized the need to address and avoid impacts to floodplains. And not to basically for the federal government not to invest in things that would exacerbate that, which they're still doing. And that's another story through the federal insurance program. There's a big movement that affected healthcare in 2016, which Obama administration, which was that any federally funded healthcare institution had to abide by the 500-year floodplain. That's the strictest level of flood protection standard. Makes sense, right? If our taxpayer dollars are going to be invested in a new hospital that costs hundreds of millions of dollars, let's build it so it doesn't flood, right? Of course, then you'll see subsequently was 2021 rescinded, and then 2020. Actually, I'm sorry, 2017, it was rescinded. And then in 2021, that act was rescinded. So we're kind of going back and forth. It hasn't been rescinded again. We're kind of waiting for that to happen. But, we're all planning for this, dealing with this crazy world. And then the last thing I'm going to talk about is the appropriate scale to deal with some of these issues. And slide on the left, it's in Florida. It's a doctor. He built to the latest standards, fortified, elevated, the whole thing. And you can see this is after a hurricane. And the question is, what good is resilience at the building scale if you have no way to get to your facility, to your building? You have no community, you have no amenities. It's just, so, my focus has been at the scale of the community. Cities are dealing with that. Which is wonderful. And appropriate. Mayor Bloomberg launched after Sandy one of the first citywide, maybe the first major citywide strategic plan for resilience, and that took a lot of political capital. People were at that time, they were still trying to get back to their homes, reopen their businesses, and he said, "Well, I'm going to." Do a long-term plan for the next, decade, several decades, and other cities have followed suit. And, I think that's something that's going to have to happen again and happen again. So I'm going to end on that.
Trevor, I think I'll introduce now. So thank you, Art. That was terrific. I really think it set the stage extremely well for what clinics can work on as well. And so we have two more speakers, Dr. Caleb Dresser, who's a practicing emergency physician, whose work focuses on two key questions. First, what does climate change mean for our healthcare system and the patients we serve? And second, what can we do to address this situation? And answering these questions, if you read his bio on the School of Public Health website, talks about this meant building a research portfolio that includes developing and testing resources for clinicians and administrators to understand risk to healthcare facilities, which again, highlights a toolkit that he's put together with many other resources that are available. Also, following Dr. Caleb Dresser will be Dr. Latoya Storr, who based in the Bahamas, who has firsthand accounts to share as well. But some of Caleb's roles include being an assistant professor of emergency medicine at the Harvard Medical School, an assistant professor of environmental health at the T.H. Chan School of Public Health, assistant director of the Physician Fellowship in Climate and Human Health, and as well as serving his patients as an emergency room physician. So with that, I'll turn it over to Caleb. Please speak to you.
Thank you. All right, I'm going to spend 1 minute getting slides up here because yes, the doctor comes with slides. Let me just get these shared and we'll make sure they're working properly. And
I want to share the, yep.
Where was the?
It was under the video. Under, oh, there you go. No.
Success.
Yeah.
All right, good to see you all, and thanks for taking a little bit of time this evening to talk about this issue. My name is Caleb Dresser. I am a practicing emergency doc, and I spend a lot of time working with a team of folks here at the School of Public Health at Harvard Sea Change to develop and test and deploy and collaborate around the continued redevelopment and co-development of resources to serve healthcare organizations, clinicians, healthcare administrators, and most importantly, our patients. We have a lot of work to do. I do include a disclosures slide. A fair amount of the work described here was supported by gifts from Biogen and later from Johnson & Johnson. I've also done some external consulting work with various entities. No commercial products are discussed. I want to start with two sets of images that I think capture for me both my own personal journey as a medical student and then physician in understanding what we're dealing with, and some of the different complexities we have to deal with when we think about this issue. The first set of images here are what you get if you type climate change into the typical photo search engine. And what you get is polar bears, power plants, and protests. And those are absolutely part of the story of climate change. But I would argue that we are better served by looking at the impacts we are seeing today and also the work that people are doing to prevent future climate change and to adapt to what is happening. So we need to think about storm surge flooding, as Eric described in the previous talk. We need to look at what is happening in architecture and design. We need to look at what's happening in community engagement and everything in between. So to frame this from the standpoint of health and healthcare, I want to introduce two timelines to this very famous figure from the most recent IPCC report. What we're looking at here are some climate stripes, a very elegant design format for showing future temperature change at a global level. And on the right-hand side of this image, you can see there are 5 different fingers here. There are 5 different possible paths that are mapped out in this report, ranging from very high to very low emissions scenarios. There are 2 key points from the figure that we're supposed to take away. First, that what we do matters, right? There is a much darker shade of purple in that very high emission scenario, meaning a much more concerning and potentially, for many of our patients, lethal future. But second, every single one of these trajectories involves substantial future climate change that we will experience over the course of our careers and over the lifetimes of the buildings that we design and build today. So investments in reducing future climate change clearly matter a lot. And even if we make those investments, we also need to be simultaneously preparing ourselves, our patients, and our healthcare system to deal with the impacts of climate change, because they will continue to escalate over the course of our careers and over the lifetimes of the facilities that are designed today. I'm not going to dive deeply into the physical impacts on healthcare infrastructure because I think we just got a really good presentation of what those are. There is a lot to talk about in other locations, for example, wildfire risk in California. But suffice to say that the physical threat to healthcare facilities is substantial. I do want to add that beyond the 4 walls of the hospital or the clinic, there is also a lot going on in our patients' lives. Some of this is really about safe housing in a changing climate. Some of it is about safe air, and some of it is about maintaining access to healthcare that a lot of people depend on for their continued well-being. So climate change impacts things through a lot of different mechanisms, ranging from short-term shocks, such as storms, hurricanes, to very long-term changes in things like the availability or price of water, the degree to which you might be exposed to mosquito-borne disease. And these impacts are geographically heterogeneous. They're going to be very different in different locations. In terms of who's at risk, as with any issue in public health, there are enormous differences in what different individuals within our society or between societies may face. The figure on the right is an image we developed in collaboration with AmeriCares and the Philippines Department of Health to communicate some of the different patient populations in the Philippines that might be particularly at risk during very hot weather. And this was really interesting because we developed this with a number of nurses, doctors, public health professionals, patient advocates, and others who are used to dealing with heat. The Philippines is a hot country, it is a humid country, and yet we're saying we are seeing heat that is dangerous in a new way just in the last couple of years, and we need to understand where limited resources need to be focused. So when you do this exercise, whether it's with coastal flooding or with heat exposure in an urban environment, there are certain patient populations that jump out, and there are certain members of the broader society that pop out as being important to address from the standpoint of preventing health impacts and ensuring access to care when those impacts do occur. So when we step inside the walls of healthcare, I just want to share two images that build on some of what you saw in the last presentation, which is what actually happens within healthcare when the worst happens, when the floodwaters rise. The image on the left is from Massachusetts, one of the wealthiest states in one of the wealthiest countries on the planet, with what many would regard as an enviable healthcare system. There are some excellent hospitals here. State level, most of my patients have insurance practicing here. And yet, this is what happened in a cloudburst event. This type of event has become 70% more frequent in the last 60 years, according to what you get when you add up rain gauge data looking backwards. No modeling required. This is simply historical change over time. So we are expecting to see more of these extreme rainfall events that flood hospitals. We're expecting to see more hurricanes in the southern United States and along the eastern seaboard. The locus of maximum intensity, where a hurricane is most powerful, is actually moving poleward, according to some research in the Atlantic Basin. And so we need to be ready for physical impacts on healthcare in parallel with preparing to serve our patients. So I want to present one flowchart. You cannot get through a talk from Caleb without one flowchart. I just finished up a class here at the Chan School in which we had to present the students with a 40-page PDF of all of the flowcharts we had gone through in the class. This is the one I've picked for today because I think, on this event, I think we have people from a lot of different backgrounds. And I would argue there is something here for everyone, right? If you trace the chain of cause and effect from what we are doing in our society today through to its consequences in terms of the impacts on an older adult who lives alone on the third floor of a triple-decker in Boston and doesn't have air conditioning, and whether she can access healthcare when she needs it, and whether she has health harms during a heat wave, there are a lot of points where we can intervene. There are things we can be doing within healthcare to reduce its carbon intensity so that we avoid being part of the problem. There are things we can do at a societal level to reduce global or national or local greenhouse gas emissions. There's also a lot we can do to enhance our resilience, both within healthcare and within the broader constraints of society. Some of these things are well outside my expertise as an emergency physician. These are things like, where are those transformers located on which our electricity grid depends? Who is making sure there's regulation around critical infrastructure continuing to function during a flood or a heat wave? Are we actually making capital investments in adaptation now to deal with hazards that haven't yet occurred but appear increasingly likely to occur in the next couple of decades? These are big questions. What we're going to focus on in the second half of my talk today, however, is the top right corner here in dark red, which is what we can do within healthcare to prepare not only our healthcare facilities, but ourselves and our patients to anticipate hazards that will occur and, as much as possible, reduce risk and ensure continuity and access to care. What can we do? Well, within that space, there is a lot. And if you talk to any given individual, I think there's some piece of this that is most aligned with their skill set or their interests. In some situations, the right answer is clinical, right? We need to be able to provide effective counseling to a person who has physical mobility limitations on what they need to do before a predicted hurricane. Some of this is educational, developing educational resources, perhaps for clinicians, perhaps for community members, perhaps for decision makers who don't necessarily fully understand the impacts of climate hazards on their constituents. There's a lot we can do at an institutional level. Some of this is institutional adaptation action. Some of it builds on educational and clinical solutions and helps them scale. And finally, there's a lot to be done with policy. Things have gotten complicated this year in the policy space, but I will say there is a lot happening at different scales, right? Some of the most effective policy solutions from an adaptation and resilience space come from people who understand local hazards and local risks. And so there's a lot of state level and city level policy opportunity. And then all of this needs to be underpinned by research, both climate research to understand the hazards we are facing, the risks we are facing, the storms to come that are something we need to imagine and internalize, even though we have never seen the floodwaters get that high yet. And then also research to test whether the solutions we are developing actually work. We live in a world of limited resources. We need to make sure those are deployed effectively where they will be most useful. And research can help us track what's working, what's not, and how much it costs. So I'm going to share a few of the resources we have been developing here at the School of Public Health at Harvard Chan Sea Change. This is our Center for Climate, Health, and the Global Environment. And the basic idea here is sketched out in a essay by, among other people, Dr. Ari Bernstein during his time here as acting director of the center, who really laid out this key observation that we have a lot of people at risk in our society, and if you want to figure out where they are, a pretty good starting point is clinics that serve lower income or otherwise marginalized populations. Clinicians working there are generally trusted members of the community. They get face-to-face time with some of the highest risk people who also stand to gain the most from interventions to address that risk. And it can be an opportunity to also, if you're working collaboratively with people in these settings, to learn a little bit about what they're already doing or what might actually practically work to serve some of those highest risk people in our society. Once you start developing these types of solutions, there is also an opportunity to scale expand their use across the healthcare system. So I'm going to give you a quick single slide on some of the resources that we have developed here. The first of these is the Climate Resilience for Frontline Clinics Toolkit. The initial version of this was developed by Ari Bernstein and collaborators at AmeriCares a few years ago. I took over the project a little more than 2 years ago, and we wound up deploying this in 19 clinics across the United States, did qualitative research to understand how a nurse practitioner in rural Texas actually was using these resources, what was working, what was not, how we could improve it. We convened expert working groups to build on the initial version of the toolkit, and we released an updated version last September. This has now been downloaded more than 20,000 times, and we've had more than 40,000 views of the website on which it's hosted. So I like to think that this is getting used in some of the settings for which it was designed. Building on that toolkit, we did a similar process in the Philippines in collaboration with not only AmeriCares, but also the Department of Health of the Philippines, and developed resources that have actually just been released this spring that provide information not only for patients, healthcare providers, and administrators, but also for community health workers and other influential members of the community, with a focus on what they can do to help with risk reduction around extreme heat, flooding, and tropical cyclones. These are resources that we released not only in English, but also in Tagalog and a couple of other local languages in the Philippines. And these are now in use, and actually during a heat wave in the Philippines, were deployed out and sent out to about 4,000 clinics in the Philippines. Returning to the United States, once you have resources to guide how do you provide counseling to a patient around staying safe during a heat wave or preparing for a hurricane, the next question is, when do you use these resources? And so we also developed a alert system. This was in collaboration with Climate Central, that pulls weather data and weather forecasts, compares it to historical information on historical temperatures on a zip code level, and then allows clinicians to sign up to receive an alert when the heat in their location is expected to be dangerous to their patients based on historical epidemiological data and some modeling. We've had almost 200 people signed up for these now as of this spring, and are gathering feedback from them on how to make this resource more useful and more effective. Finally, hot off the press in the beginning of April, after about 2 years of development, really collaboratively with a number of these frontline clinics, are resources on risk reduction in the community. What can a health center do to collaborate with a local government or with a local soup kitchen or a local Meals on Wheels program to reduce risk to people in the community so that they don't require the services of an emergency physician when the heat gets hot or when the storm arrives. So we have 2 packets right now. One is focused on heat, one is focused on wildfire smoke. And these are now have gone through a review and initial utilization by 140 clinics as part of that project. All of this work has gotten a fair amount of media attention, which has been exciting, and I think has helped sort of put Harvard Sea Change on the map as a place that development of these resources is happening. And as we look ahead, we are now collaborating with people around the world to build out this type of resources to support clinicians, patients, healthcare administrators, and community members in other settings. There are collaborators working on this right now in Cyprus for the Eastern Mediterranean. One of the graduates of our fellowship program is leading work on this in South Australia. And we would like to see a future in which these resources are further developed, are tested more extensively in clinical practice so that we can continue to refine and focus on what is most effective at meeting the needs of our patients and the clinics that serve them, and expansion to other hazard settings and populations. So I will close there, happy to chat at the end for questions. Now, I would like to introduce Dr. Latoya Storr. Latoya is an emergency physician in the Bahamas. She directs an emergency department in Grand Bahama. And she is also a graduate of our programs here, not only in climate change and health for our physician fellowship, but she also completed a disaster medicine fellowship here with our team at Beth Israel Deaconess Medical Center. And so she has been working to bridge the gap between disaster medicine and climate change from the standpoint of practicing health professionals who are at the front lines of dealing with impacts. And she's going to share what I feel is a really powerful story about what climate change impacts look like in practice in a hospital setting. So Dr. Storr, over to you.
Hi, thank you, Caleb, for introducing me. I'm very excited and happy to present my experience as a case study of actually what this looks like in practice during a climate change hazard event. I'm trying to see if my slideshow shows. Are you seeing presenter's view?
Looks
Yes.
good to us.
Okay, all right. So yeah, so basically I'm presenting Hurricane Dorian, the Grand Bahama experience. As Caleb noted, I am an emergency medicine physician, and I had actually completed my residency training in 2018 in Nassau. So I had just been home less than a year. As a senior, which y'all would consider an attending, I would call a senior registrar consultant back in Grand Bahama. So a little background. Basically, as far as the Bahamas, for those who don't know, the Bahamas achieved its independence from Britain on July 10th, 1973. So we're a very, very baby infant nation, only 52 years old. But ever since then, we are now a fully self-governing member of the Commonwealth, as well as a member of the United Nations, the Caribbean Community, and Organization of the American States. It's important to note that Bahamas although a group of chain of islands has a extension of body of water as well as land mass that extends from 760 miles from Florida in the northwest all the way to Haiti in the southeast. It's important to note we consist of 700 islands, 2,400 keys, and this is roughly about 5,400 square miles. 30 of the islands are inhabited. And it's important that we're virtually flat. Average elevation is about 100 feet. The highest point in the Bahamas is on one island, Cat Island, at about 206 feet. So there's many places in the Bahamas that is actually at or below sea level. And we are a population of less than about 400,000 persons. So therefore, that means that the government of the Bahamas is then challenged with providing care along this whole chain of islands. And there's only two hospitals, government-funded hospitals in the entire country. One is the tertiary level hospital that's on the island of New Providence, the Princess Margaret Hospital. And that contains specialties such as neurosurgery, neurology, and then my hospital, the Memorial Hospital on Grand Bahama, which is a local institution, community acute care center on the island that roughly serves about 45 to 55,000 persons as a population. And so what's important to also know, just to give a background history, I always show this slide, and this slide is showing the significant hurricanes that have actually impacted Grand Bahama since 2000. So as an archipelago, we sit right in Hurricane Alley, and therefore our homes, those that are able to afford it, the government mandates, and on my island, Grand Bahama, the Port Authority mandates that the structures are reinforced with steel in the roof so that they are able to withstand at least Category 4 homes. However, risks are higher for those persons who aren't able to meet those standards. And so it's important to know when you look at this list, since 2016, there has been at least 10 Category 5 storms. And the majority of them you can see has actually been on the list. Now, when we look at these hurricanes, it's significant to know when we look at the names, naming of hurricanes has just been something done in recent history. Within the 20th century, usually it was related to an event, an historic event in the US, in the West Indies. It was related to saint names. It wasn't until around the 50s and 60s actual human names were used, and around in the 70s, due to the rise of the feminist movement as well, alternating, because initially it was all females and it gave a negative connotation that these destructive terms had female names. And so it started alternating between male and female in the 70s. And it's important to note that this list rotates every 6 years. And as the World Meteorological Organization decided, when in 2005, when they had 28 storms, and they usually use 21 names, and in 2020, when they had 30 storms and they ran out, they would use the Greek letter alphabet. And what they came up with in 2021, when they ran out and they had multiple Greek letter alphabet names, they changed and decided to develop an alternate list. The reason why I'm saying this is because when a storm has created such a level of destruction and has created such loss of life, the names get retired. So it's important to note that this year marks 6 years since Hurricane Dorian, and now the same list of names that was used in 2019 has now been put back in circulation. And so it's important to note that Dorian, because of the destruction that it caused, has been retired. And so in its place now, it's Dexter. So when I want you to look at this note, the Ian and Milton, although they did not impact Grand Bahama, they did not make landfall. The wind bands, because of the level of destruction that we still have post-Dorian that we're still trying to recover, did create a lot of level of flooding and storm surges. So on September 1st, 2019, Dorian made landfall on the island of Abaco in the Bahamas, and it had wind speeds of greater than 185 miles per hour. And it had wind gusts up to 220 miles per hour. It sat over the island of Grand Bahama as it moved eastwards for 48 hours, moving at 1 mile per hour. We had storm surges of over 20 feet, and we had rainfall of over 30 inches. So it created significant flooding. And this video here sorry, this video here that you see, the picture that I'm showing you is actually the front door of our accident emergency department. And this video is actually showing you persons standing outside, even those persons that were in lockdown, they're actually standing on the porch. That porch where you see the steps, they're actually standing on the porch as the flood waters rose and started to intrude into the hospital. And why is this significant is because at that time, the accident emergency department was one of the newer parts of the hospital. It had just been renovated in 2012. And when it was renovated to be 4 feet higher than the rest of the hospital. And so as the floor waters began to rush in, the rest of the hospital, which was the wards, the ICU, the administrative block, the maternity ward, pediatric ward, operating theater, sustained 4 feet of flooding. So those parts had to be evacuated into other areas of the hospital. And what happened was at one point, the maternity ward, the decision was made to take some laboring patients as well as the obstetrician that was on call to site off hospital that was supposed to be used in the event that you had to evacuate the hospital. However, during their evacuation, the ambulance flooded out. And the obstetrician as well as 4 pregnant women had to be housed in a nearby home. Believed 2 babies were actually delivered in the home during that time because of the challenges we're trying to get to the clinic. As stated before, ICU was moved into the emergency room. It was placed inside our trauma bay. The pediatric ward, the nursery actually had to be put inside the radiology suite. So you actually had cots that were actually next to the CT scan. Also, the ward patients were actually moved into our emergency room bay. And at the time, when we lost power and the generators failed because they were actually on the ground level floor, that meant that the electronic doors were sealed. So it saved them from the rushing flood waters, but it meant that they were virtually locked in since they couldn't get out. And even though the emergency room did not sustain 4 feet of flooding, it did sustain 1 foot of flooding. And the challenge was not so much from the rushing waters outside, it was because the flood waters actually overwhelmed the sewage system. So they actually started to have sewage seeping into the emergency room. And so there was no running water. And so the bins that were actually put inside that we normally put inside when we know we're going to lose water, that's what you use for your hygienic needs for those persons that were inside the hospital. And actually the seepage of water, that was what was actually used to actually flush toilets. So that was a challenge to try and maintain hygiene during that time. Can you imagine the difficulty of trying to do septic techniques there? Because at one point there was a makeshift theater inside the trauma bay in one room. So that was definitely a challenge during that time. This picture is actually showing the significant flooding that actually changed the topography of Grand Bahama at that time, whereas the majority, as you can see, almost about 60% of the island had been placed underwater during flooding. And this picture is actually showing you the path that Dorian made and what level it was when it cut through the path of the Grand Bahama. And one of the things that actually saved Freeport is the fact that Freeport is actually on the southern part of the island. And the storm actually decided to make a slight move shift and move north. So that actually saved the majority of the city just by sheer inches of movement. Now, this video.
We were totally underwater. It was something that we had never experienced before. We've been through numerous hurricanes, but this one came with the water that came up to the level of most of our monitoring equipment, our beds, medical, surgical materials, all of it gone.
So that was actually a video that was made by one of the NGOs that had came, and they had interviewed the then hospital administrator about the level of destruction and the damage that the hospital had incurred. So as stated before, Dorian sat over us for about 2 days. And so persons were in hospital for about 3 to 4 days. And the all clear was not given until about September 4th. But due to the foresight of the then clinical director who had the mindset to tell staff, remove everything from ground level, unplug all the computers, all the electrical equipment, put them on top of what empty stretchers, put them up high to save the computers and all the monitors as well as the pumps. Our equipment basically was spared. It was a blessing and a curse, because as you can see, what ended up happening was Samaritan's Purse did come, but in the aftermath of the hurricane, we basically saw a lot of the trauma that had occurred. We saw a lot of skin infections that occurred because of people that had been sitting in water for about 4 days. Critical cases had to be transferred into the capital at PMH due to the assistance of different NGOs. Samaritan's Purse, which was the NGO that developed and gave us a field hospital, set up shop in late September. So we were about 2 weeks into having our own response, dealing with what we could deal with. And the field hospital was established from September to November 2019. Now, the challenge was it provided a surgical ward, a medical ward, and an ICU and operating theater. However, it did not provide a pediatric ward or obstetric capability, so that had to be dealt elsewhere. So in this slide here, the blue building is actually a clinic also on the island. And this is where the pregnant people were trying to evacuate to when they stalled out. So after Dorian, this became the site where obstetrics patients were housed as well as pediatric patients, and also the operating theater we were able to use. And so we were in the field tents until about April 2020 when tropical storm just developed. So, hurricane season is in June, but we had a tropical storm that developed in April. That meant that we had to decommission the tents. And so that gave us a challenge into trying to figure out where else we're going to go. So that church here that you see, we had used its hall to become the medical ward for male and female patients, medical surge ward. Of course, the accident and emergency department, our trauma bay once again became ICU. And later what ended up happening was during the renovation of the hospital, a mobile operating theater was actually attached to the accident emergency department so that cases could be done while the hospital was getting repaired. So this picture slide is showing the before and after structure. So there were many challenges when it came to the renovation. The most significant challenge was that Dorian occurred September 2019, and then less than 6 months later, here comes a global pandemic that shows up. And so now we're going into a pandemic with virtually no hospital. And so some of the attention and the funds had to be diverted into building an isolation unit and also trying to retrofit the Cancer Association building to house COVID positive patients. And due to the prolonged nature of renovations that have caused a significant strain on my accident emergency department. So like I said, equipment, we were able to save equipment. So that was both a blessing and a curse, because basically for the longest time, the emergency department was the hospital. So there's still some, even now, 6 years later, there still remains some persistent challenges. As stated, I say my emergency room is kaput. It needs a lot of work. It has been the workhorse for the hospital, and that's being challenged with overcrowding now for over 6 years. And so that is a challenge. What is occurring now is that the government is actually developing a healthcare campus on the island of Grand Bahama and Freeport, in which where they're trying to incorporate multiple clinics as well as a new hospital that is supposed to be climate resilient. That is currently under the construction while we're still in the renovated Ram Memorial Hospital. And of course, there's a strain in the workforce. I see a link to a paper that I did that concerned the staff members that worked through Dorian, discussing the level of moral distress that occurred. Why it was done is because we had a significant challenge, and we still have a significant challenge in retainment of our nurses. But nurses have experienced significant burnout, high levels of moral distress. And so that created where our leaving rate of our nurses jumped from at 1.9 to 10 a year to 20 and 21 a year. That does not sound a lot for you, but an island that has about 200 nurses, to lose about 20 nurses in a year is quite significant. And so that is a challenge for us, as well as still some deficiencies in technology and data that still need to work upon. However, the government is working to try and figure out and develop resilience strategies and leveraging like the Green Climate Fund to try and secure some financial funding to help retrofit our healthcare facilities. They understand definitely need for us to build back more climate resilient. So that's why the upcoming structure is supposed to be, it's built higher, as stated by the previous Eric and New York had said, the foundation has actually been lifted higher. It's actually been constructed on a higher part of land. We're all flat, but it's a little bit on a hill to try and combat the effect of storm surge and sea level rise. And also trying to empower the workforce through education and community outreach by having different workshops. Have you noted, Caleb had noted that he had worked with the Ministry of Health to sensitize healthcare workers about climate change and climate change impacts on health. And so that's the way forward. And these are my references. So thank you for listening, and I was happy to share what this looks like in real time, dealing with a climate hazard up close. And now we're back in hurricane season again. Thank you.
Thank you, Dr. Storr. We are, as you all know, we're a little bit behind time, so but I do want to make room for questions. We don't have any in the chat, so if anybody has, we may have one or two questions from each place. I see a question here in New York. We can go to Boston if anybody's question there. First of all, can you hear the question? Okay, we'll give you the mic. And we have time for concise questions and concise answers. So if the question becomes too long and doesn't have a question mark at the end, we will move on.
Thank you. Thank you firstly to everyone for the great presentations. You know, in the climate and health space, I think we have a lot of ideas, but it's always great to hear about how they're actually being implemented. So quickly, I think I have a question for Eric and then a quick question for Dr. Storr. So for Eric, I think the question is just, I know we're working on a long timeline, but given all the experience you have in doing these adaptations, are they paying off? Are you seeing, how are you measuring their effectiveness? And is it possible to measure in between disasters? And then for Dr. Storr, in the Bahamas, I'm curious, when you were responding to Hurricane Dorian's effects, were there any resources or trainings that you tapped into most frequently, or that you were like, yeah, I'm glad I knew this, and this is what really helped me figure out the next step of what I needed to do? Because there's a lot of resources, and it'd be good to know what's actually useful in these situations. Thanks.
Eric, we'll take Eric first, then Dr. Storr.
Well, unfortunately, it's hard to tell if they paid off until you actually have to use them. No, in New York, it's yet to be completed. And so it's kind of difficult to say. I know, you know, there's the Thames barrier in London, and then there's the large, I don't recall the name of it, in Rotterdam, and they have been deployed. But you know, that's the issue, is you just don't know until it happens. And then there's the question of, if it didn't happen, did you spend your money unwisely, or, you know, were you just protecting? And now that the various charts that show the probabilities at different heights and so forth. So, you know, again, it's that bet you're making on how much protection to provide. You want to provide the minimum, but you don't know until you made the wrong choice, right? So was not an answer.
No, it's helpful to know what we don't know. Thank you.
As far as the question about any resources to help me with response, I would say no. So one of the important things to note is, like I said, we are no strangers to hurricanes. This is a way of life. This is something that all Bahamians, all islanders are quite familiar with, because we know this is something that we deal with every year. It comes around, just like Christmas, every year it comes around. And so we deal with a lot of like preparedness. So some of the things that we do in preparedness for the storm is we do have registries of different patients. Some of our patients that are like special needs, we call them to determine where they are. We set them up in different shelters. If they're very ill critical, we usually put them in the shelter that's right next to the hospital, so that if push come to shove, they can come to us. Also, our dialysis patients, all of our patients, we know that we have to try and top up their dialysis, because we don't know what will happen to the dialysis center after the storm, which was a challenge, because even though the center still stood, there was no electricity for weeks. Also, the pharmacy, preparing the pharmacy to get persons, ensuring that community outreach, letting them know that make sure you get your prescriptions for your chronic medical illnesses. Make sure you have enough for at least 2 weeks, ideally a month, because you don't know when you'll be able to reach the hospital again to get access to your medication. So I say a lot of our stuff, I think, is more in the before than as far as the response. When you're in it, I was not in hospital. I was actually out of hospital. So we had 2 teams. I came in afterwards, and I was just basically dealing with whatever came with me as May, and also love the help, but you also have to protect your population. So not everyone can help. So you have to stand and almost stand guard to be like, thank you. But we're charged with protecting our patients. So a lot of times that had occurred too, to be like, thank you, but can you just wait right there? So that was some of the challenges that we had. And so you learned that was a learning experience on the fly.
Any questions in Boston? We have a question that was asked in advance, but want to give a chance to folks in Boston first. If not, the question that we had in advance that somebody submitted, and this might go for Dr. Dresser. If folks here want to advocate for resilience in health clinics in their communities, what institutions, civic organizations would you recommend that they typically approach?
I would say the right answer to that is whatever you are well connected to within your field. I would see climate resilience as a society-wide issue. If you are an architect, I suspect that there are architectural organizations that can speak to how to do this better from an architecture standpoint. If you're a physician, certainly the American Medical Association and a number of specialty-specific associations recognize this as a threat to our patients and our hospitals and are engaged in some advocacy around it. So I think that there are a lot of different right answers to that question, depending on what your profession, your field might be, or what specific angle you have on this issue that you can speak to. As a physician, I spend a lot of time speaking to what I have seen in my emergency department. I've treated a lot more heat stroke than I ever expected to treat when I was in medical school. If you're in a different field, your experience of this issue will be different, and the stories you can share will be different, but I think are no less powerful, and these stories need to be shared.
Final question from New York. Okay, nobody from Boston? I want to be fair. Okay, we got one more question in New York. Boston's quiet today.
Sorry, yeah. This question is for you, Caleb. I've been tracking the toolkit that you guys had put out, you and AmeriCares, and it's been really cool to see its development. I'm curious though, when you said that you've updated it back in September, you released an updated version back in September last year. Was there any feedback that was surprising, or what did you guys get feedback on? What was the most useful element of the toolkit? Or like maybe what wasn't there, kind of just like your thoughts on that area in general.
Yeah, this is a great question, and I think speaks to a really important thing we need to be doing in general as we try to develop solutions, which is field testing them and listening with open ears to the response. So We did a lot of semi-structured interviews. I actually had a team of grad students working with me along with a monitoring and evaluation specialist at AmeriCares to interview nurse practitioners and clinic managers and a whole number of other folks on what was working, what wasn't, what the challenges were. Some of the stuff that came up included literacy issues. And so, this had been released in English and Spanish. One of the pieces of information we got was that it had been written at too complicated a language level. And so simplifying the written language was really important for the patient population that these practitioners were working with. We got feedback asking for more pictures, fewer words. And so the redesigned resources included a lot of new graphics. We got feedback saying, hey, for a lot of the highest risk individuals, there's somebody in their life that is helping out. Maybe we should have some resources for caregivers. So the revamped toolkit included guidance for people who are taking care of a family member who's dealing with chronic illness. So actionable guidelines for that group. There were also some really interesting things that I think you could continue to debate. We had to reach a decision on these. Things like, do you use the words climate change in patient-facing materials? We had some feedback from users of the toolkit that said this was really powerful as a way to highlight for people why this now matters more for some of these hazards. And we also had some feedback that said, when you get to the words climate change in this patient I'm working with refuses to hear anything else I'm saying. And so we wound up removing the words climate change from the patient-facing part of our climate change toolkit. And that was a conscious decision after a multidisciplinary discussion about the right path forward, figuring we need to be able to serve everyone, and that if a patient is someone who wants to hear about climate change, that can be shared verbally by the practitioner. But we want to make something that works for everyone, even if what they're ready to hear is simply floods are dangerous, rather than floods are getting worse because of human-caused climate change. So those are a few examples of it. We actually published a paper a couple of months ago delineating this in a lot more detail, and I'm happy to share a link to that, which includes some of the quotes from the users of the toolkit.
I think we'll at this point close out the live session, although we will allow folks to go to breakouts in their locations or online. I think Dr. Storr was going to stay with the online community. But I just want to highlight just a quick takeaways. I mean, what comes through clear is that clinic resiliency isn't just a topic for healthcare professionals, that the handout and resources that the speakers provided talk to what the role of providers, administrators, patients, caregivers, as well as building designers. We heard about the importance of policymakers. So I think all of us will see ourselves in one of those roles and how we can help to contribute to activities on clinic resiliency. I think it's also very important around this series that we highlight the contributions that are being made among the faculty and the alumni, particularly at this point of which the university is under tremendous scrutiny, and therefore, showing what the value we provide to patients, to society, to all those around is critically important at this time. And I think it's great that we want to continue this series on climate and health to highlight other contributions that are being made by the faculty and alumni. So with that, I'm going to close out the live session. We can stop the recording. And I just want to thank our presenters, Dr. Dresser, Dr. Storr, Eric in New York, and also for hosting at Perkins Eastman. We're grateful, as well as to Trevor, Eleanor, Michelle, for helping to organize this event. And we hope to see you at a future event.